Well, hello, my name is Jordan Shapiro. I'm an assistant professor of gastroenterology at Baylor College of Medicine in Houston, Texas. And I'm honored to have been invited and very thankful to have been invited to give a talk on introduction to supplement use for gastrointestinal disorders. So I have no disclosures. I have two disclaimers. One is that this is not intended to be a substitute for your doctor's medical advice. So I'd always encourage you to talk to your healthcare providers about questions you have about treatments. And secondly, I'm going to use the term CAM, complementary and alternative medicine, even though we'll discuss briefly that there's been a proposed name change, and that's somewhat akin to functional GI disorders or FGIDs, and the recommended new term DGBIs, or disorders of gut-brain interaction. I'm going to use the older term CAM just for ease of abbreviation. So the objectives for my talk are going to be a brief intro to CAM, even though I know that was discussed elsewhere, but I want to give some sense of where supplements fit into the broader field of complementary and alternative medicine, some challenges and concerns regarding supplement use, updates on a few commonly used supplements for GI disorders, and then how I approach supplement use. So CAM is a group of diverse medical and healthcare systems, practices, and products that are not considered to be part of conventional or standard Western medicine. So what's in a name? So you've probably heard, or you may have heard, all of these terms used: complementary, alternative, integrative medicine. And so complementary medicine is used with conventional medicine. It complements it. In conventional medicine, I'm using it to define sort of Western or standard medicine that you get from your doctor. Alternative is used in place of conventional medicine. And so that term it fell out of favor because the question was, who's the alternative to who? And then integrative is this term that is meant to signify a blending of all the different treatment options, focused on ones that have evidence behind them, and a more holistic approach to the view of health. So not just treatment of disease, but actually promotion of our best selves. There are three main categories of CAM therapies. The first is going to be the focus of this talk: natural products and supplements. Listed some examples of those. Mind-body medicine. You can see some of the therapies under mind-body medicine are actually not really alternatives or complements. They're really considered some of the best therapies we have for disorders like IBS. So, cognitive behavioral therapy and gut-directed hypnosis have really good evidence and are really moving into kind of the mainstream of how we recommend treating those. And then some systems of medicine like Ayurveda from India, traditional Chinese medicine, and functional medicine. So how common is CAM use? 30 to 45% of the general population of adults use CAM therapies. I listed some of the numbers for GI-specific conditions. You can see functional GI disorders, a little over a third. There's a big range when you look at all the studies from across the world in IBS, but it's 21 to 73%. Most of those fell around 50%. Inflammatory bowel disease, 21 to 60%, and then chronic liver disease, 27%. So what are the predictors of CAM use? This is when we look at groups of people who use CAM and don't use CAM, what are some of the factors, or what are some of the characteristics of the people who tend to be more likely to use? So female, higher education, poor health status, which may signify some kind of desperation or searching for something outside of the box, a holistic orientation to health, an interest in spirituality or personal growth psychology, and I think important to note, which has been shown by some studies within GI as well, including some by Dr. Doug Drossman, that it's actually not usually due to or associated with dissatisfaction with conventional medicine. So people aren't, ticked off at their doctors and going to find some alternatives. They're trying to find ways to get better than they were able to get with traditional therapies. When you ask patients why they use CAM therapies, they often state that there's a failure of the conventional therapies to fully alleviate their symptoms, a desire for a more natural approach, a sense of control that comes from seeking out therapies and making some of those decisions on their own, and then health promotion as opposed to just a mere treatment of disease. So I don't just want the problem to be better, but I want to really feel like I'm thriving. And then importantly, disclosure of CAM use to physicians. So most of the time, the decision to start a CAM therapy is not coming from a physician. Most of the time, it's started without even consulting with a physician. CAM use is often not disclosed to physicians at all, even once it's started. So that is a big range from 30 to 80% of in different studies that are not disclosing this to their providers. And disclosure varies by CAM use. So I included this because it highlights that in general, patients are more comfortable sharing the use of some of the mind-body therapies like yoga and meditation, and less comfortable sharing the use of herbs and supplements. So about a quarter of patients disclose those to their physicians. And when asked about reasons for not talking about this with physicians, the biggest factor was physicians just not asking about it. There's a significant portion of patients who also felt the physicians didn't need to know. These were natural supplements, they were safe, it wouldn't impact their physician's treatment. And then the least common reason was due to concern that physicians would discourage use. So I want to talk a little bit about some of the concerns and controversies surrounding supplement use. If you're a provider listening to this, some of these may be the reasons that you've been a little standoffish towards supplement use. If you're a patient, these may have been some of the things that you've kind of felt your providers pushing back about regarding supplement use, but I think they're important to bring up. One, for some supplements, there are known risks. These may be direct side effects that can be as mild as some additional GI upset, or as severe as liver failure, and some herbal supplements that have been known to cause liver failure and even require liver transplant. And then there are a lot of indirect side effects, and I actually worry more about these because I think that they're more common and sometimes more insidious, meaning we don't think about them as side effects, but those might include interactions with medicines that a patient is taking, deferment of proven treatments. I have a patient who stands out in my mind from many years ago who stopped her insulin to take mango powder extract she had heard about on a TV show and ended up in a coma in the ICU, and unfortunately survived. But she deferred a really well-proven treatment for her diabetes in favor of something she felt was more natural. The cost of supplements is significant, and I worry also about supplement burden. So I have a lot of patients who are taking 5 to 10 different supplements a day, and it can become quite a burden, just like taking a lot of prescription medications can. For many supplements, the risks are also unknown. And so I just wanted to point out, not knowing that something is bad or how bad it is doesn't mean that it's good. So sometimes we just don't know, and we can't just assume that it's okay because we don't know. So why are we still in the dark? Well, there are probably a lot of reasons, but there are over 80,000 herbs and dietary supplements on the market. Federal law does not currently require supplements to be proven safe by the FDA before marketing, so they're not held to the same standards of going through rigorous clinical trials and proving safety and efficacy that a drug is. There's little regulation or standardization to verify what's actually in the bottle. So even if you said, I think melatonin might help you with your sleep, or there's actually some research using it for IBS, the dose, when some researchers looked at a bunch of different products with melatonin, range from significantly less to the labeled dose to up to almost 500% of the labeled dose. And so for melatonin, that might make somebody dizzy or a little sleepier, but for other therapies, that could actually pose significant harm to the patient that there's no way of knowing that they're at risk of. And then there are a lot of limitations in the research. There's a lot of lack of rigor. So blinding, which is the researchers and the patients both not knowing what treatment they're getting so that they're not biased. randomization so that patients who enroll in a trial are equally likely to get the treatment or placebo. Controls, typically that's a placebo, so we know the therapy performs in such a manner compared to someone who's getting basically a dummy pill or nothing. And then FDA endpoints, which, for things like IBS, conditions like IBS, there are really stringent criteria that are used to judge whether or not a prescription drug is effective. And most of the studies of supplements don't use such rigorous endpoints. There's also lack of funding. There is an NIH center. So one of the 27 centers in the National Institutes of Health is dedicated to CAM-related research. But a lot of the studies they funded have not been published or have had negative results. And then a lot of studies use combination therapy. So that might be peppermint and caraway oil or turmeric with a myriad of other vitamins and things. And it gets really hard to know, what is helping and what's not helping. And a lot of these herbs in the test tube have a lot of different effects on different receptors and really broad mechanisms. And we often take that and kind of assume that it does all of those things in the body when there's not really good evidence for them. Physicians are also not well trained in the use of CAM. There's no standardized training in medical schools on how to even approach these therapies. There was a collaborative that was together for over a decade that was able to get some additional training into medical schools. But again, this is pretty limited for most people going through medical training. And then I wanted to just highlight this because I think these are some things that compel a lot of people. And I'll include myself. At times I've been compelled to feel like, this therapy works or is good because of these things. And these are things that are fairly non-scientific. So the first is this appeal to tradition or antiquity, which is, this has been around for thousands of years, therefore it must be good. And of course, there are a number of things that have been around for thousands of years that we know are really dangerous. But this is a common argument, especially when there's lack of data supporting something. My friend's celebrity or TV doctor said it cured their blank. We know that there's a certain TV celebrity doctor who over half of the claims he's made on the show were demonstrated in congressional hearings to be false. But that is very compelling to a lot of people who watch such shows. I got the more expensive one, or I bought this at my doctor or chiropractor, could be any provider's office. And of course, there's obviously sort of a conflict of interest when you're selling supplements out of your office. That's sort of an incentive to sell them. It had all these different properties. There's anti-inflammatory, anti-pain, immune stimulating. And this again gets to this idea that just because it demonstrates some properties in a lab experiment doesn't mean it will have those effects in a human study. And oftentimes we don't get to the human study to really sort that out. And then they didn't use the whole plant or herb. So, in this attempt to reduce things to the active ingredient, are we missing out on some collective properties of the plant? And most of the time we don't know that the whole plant is any different than the active ingredient. So highlights of a few common GI supplements. Ginger, commonly used for nausea. We think this works similar to a medicine called Zofran or ondansetron, which acts on serotonin pathways and blocks serotonin. And so the evidence for efficacy, there's some for prevention of postoperative nausea and vomiting, although there were some positive studies. And when they pooled all of the studies together, there was no difference in people getting ginger and not getting ginger. With nausea and vomiting of pregnancy, the American College of Obstetrics and Gynecology says this could be considered as a non-pharmacologic option after other things like vitamin B6 and doxylamine, which is an antihistamine, but they say it's level C evidence, and this is mostly expert consensus or opinion and not so much good evidence. And then prevention of chemotherapy-induced nausea and vomiting has been one that's kind of moved back and forth as additional studies have been done. The last large study that was done in adults anyways showed no difference between ginger and placebo groups. The typical dose I listed here comes in a lot of forms. Most of the studies are not using whole ginger, and there are some risks in inhibiting platelets, which can cause increased risk of bleeding, drug interactions, some heartburn and mouth irritation if you've ever bit into a piece of raw ginger, and then some small risk that there may be some risk of birth defects and things like that, but that's not really been well borne out. Peppermint, which we often think about using as kind of an anti-spasm medicine for functional dyspepsia and irritable bowel syndrome. There are several studies showing improvement in global symptoms. A recently published study, which was a larger randomized controlled trial, found that while it did improve abdominal pain and discomfort and IBS severity in an 8-week trial, it did not hold up to showing improvement with more stringent FDA-approved endpoints that we would require for a drug, for instance, to be approved. And I've listed, I'm not recommending necessarily IBGAR, but this is just a common preparation used in GI offices of an ultra-filtered, an ultra-purified, I should say, peppermint oil. And then the risks I listed below. Turmeric, we think about kind of anti-inflammatory, but it's been proposed to be anti-everything. And so, in irritable bowel syndrome, hasn't showed a significant improvement in symptoms. In inflammatory bowel disease, it was once kind of touted as this add-on therapy for some of the mild or oral treatments for inflammation and ulcerative colitis. Although the most recent American Gastroenterological Association, or AGA, guideline makes no recommendation based on a failure to show benefit in a big review of all the studies done. So, and an important thing to note here is that this is an example where most of the studies are using curcumin extract, but turmeric, if you were to eat the whole dried spice, is 3% curcumin by weight, and so therefore you'd need to eat a lot of turmeric to get the same amount of curcumin, the active ingredient that you can get in an extract form in smaller amounts. And then probiotics, I think, is important to note, just in that our GI Association, the AGA, recently came out in earlier June with this statement that there's really no strong recommendation in using probiotics of any kind for Crohn's disease, ulcerative colitis, irritable bowel syndrome, or treatment of Clostridium difficile, unless it's in a clinical trial. And they actually go so far as to say, if patients are taking them, there should be a discussion about whether or not they should stop them just based on lack of strong evidence. It's also recommended against, or more strongly, for use in acute gastroenteritis or a viral stomach infection, in that it's not been demonstrated to be of any benefit. And there are some instances below that I noted, which are very specific instances that probiotics can be beneficial. And I'd refer you to the guideline in that there are very specific combinations of probiotics that have been demonstrated in trials to be of benefit. Cannabis, I think this is the last one, or marijuana plants. So there are cannabinoids that are the active ingredients, or cannabinoids in marijuana. These are phytocannabinoids. There are over 100 in the plant. There are endocannabinoids, which are actually ones that our body makes by itself. And then there are synthetic ones that have been developed as drugs. The proposed mechanism of action is that these tend to block the excitatory nerves in the intestine. So in theory, there was a gut that was moving faster than normal, that it might slow things down. And then there's some anti-pain properties of some of the cannabinoids. The evidence for efficacy, these were initially studied in the synthetic form dronabinol for weight loss as an appetite stimulant in HIV/AIDS patients, and for refractory chemotherapy-induced nausea and vomiting. All 4 studies in irritable bowel syndrome used the synthetic drug dronabinol, and none really assessed symptom improvement. So there's no strong evidence that this is beneficial for IBS. The big thing about cannabis, I think that's worth noting is that none of the studies use the whole plant, but whether it's the whole plant or it's synthetic versions, it's all about the THC to the CBD ratio when you look at the risk of side effects. So THC is the component of cannabis that can cause hallucinations and psychosis and anxiety. CBD can cause some drowsiness, and so the other important points are, sometimes in trying to improve GI symptoms, we can trade one set of symptoms for others. And so in a big group of IBS patients, when they looked at all the patients admitted for IBS as the primary reason that they were put in the hospital, cannabis use was actually the biggest predictor of being admitted to the hospital. And then there's this other syndrome called cannabis hyperemesis syndrome, which is actually kind of uncontrollable refractory vomiting that's related to cannabis use and seems to go away when cannabis is taken away. So all of that said, I wanted to give a quick highlight as to how I approach supplement use, and then we'll wrap up with that. So my general approach to CAM, I wanted to quote Bill Che, who's a mentor and a personal hero of mine. He said, always leave patients with hope. And so, I start with the notion that CAM use is well-intended, and it must be serving some purpose for a patient to go out, purchase, therapies or supplements, and to use them. And so I usually start by acknowledging that and saying, I'm so glad that you're actively seeking some solutions to improve your health. Patients may also find success with therapies that we have no explanation for, and that bothers us as physicians and scientists. But I think it's okay, and we have to hold a space for being okay with being skeptical, concerned about a supplement safety, but also thankful that patients got better. And so I'll often just voice that and say, looks like I didn't finish my thought here, but I'm so glad that you found something that worked. I'd like to talk about some of my concerns and how we might try to mitigate those or monitor for potential side effects. So I think all providers need to ask about CAM use, and I think all patients should try to share this with their providers. So have they ever used any CAM therapies? What are the specific ones that they've used in the past, that they're using presently, and any that they're interested in using in the future? How they got interested and aware of CAM therapies, effectiveness of CAM therapies for specific symptoms. So, if you're using it, how convinced are you that it's actually doing what you want it to do? Because, you're still taking the burden of purchasing it, putting it in your body, at some routine interval, and we'd like to know that there's at least some perceived benefit. And then, of course, any side effects or adverse events from CAM therapies. So some tips perhaps on guiding a trial of supplement use. Make it a true kind of N of 1 trial. So define the duration of the trial, and in most cases, 2 to 4 weeks should be enough to say, is this doing anything of benefit that I'd like it to? I really recommend limiting this to one supplement at a time. And if someone's already on a supplement, they've been on it at least 2 to 4 weeks, sometimes considering a supplement holiday to say, well, maybe this has helped, but why don't we see how you do off it? Maybe the effect continues and you don't need to keep taking it every single day, or maybe your symptoms come back and that really tells us that this may actually be helping you. To the best of your ability, align your and your patient's treatment expectations, help the patient to understand the optimal dose, timing, and frequency of the recommended supplement based on the best evidence you can find. And then inform patients of potential adverse events or drug supplement interactions, noting that lack of information does not guarantee safety. So my summary, the spectrum of CAM therapies is vast, and it's natural products, which include supplements, mind-body medicine, systems of healing. CAM use is very common. It's often not discussed, but I think we need to start with the premise that it's well-intended, even though that doesn't mean that there are no risks to it. These risks might be direct or indirect with CAM, and there are a lot of challenges that providers face in being able to feel comfortable supporting and guiding CAM use. And then lastly, given this imperfect world, there's lack of regulation and standardization and rigorously conducted clinical trials with a lot of CAM therapies. patient-provider communication is critical to maximize safety, and again, I'll end with also to maintain hope that the seeking for some solution is going to be a joint venture and that there's real partnership there. Thank you so much for your time and tuning in, and thank you again to the IFFGD for this opportunity to share a little bit about supplement use with you. I've included my email address and Twitter if anyone has questions. I'm happy to respond to those on a personal basis. Thanks so much.